If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, welcome to Health Further. We have a guest episode today. We're going to learn about nutrition and food as medicine with Lauren Driscoll of NourishedRx. Lauren, thanks for doing this. Really appreciate it.
Yeah, happy to be here, Vic.
So let's. This guest episode is really about bringing in an expert like yourself. Help the audience understand your background. What brings you to today?
Yeah, sure. So my background is all healthcare. I've worked in different policy settings. I've worked in managed care. I ran the Medicare business at Oxford Health Plans. And then after the Affordable Care Act passed, I worked at Leavitt Partners, which was started by Governor Mike Leavitt, who'd been Secretary of Health and Human Services. And I'd say at a high level, we were really helping private sector companies navigate the Affordable Care Act and really navigate value-based care. But Vic, the common thread through all of those different healthcare settings for me has always been a focus on vulnerable populations. And, that comes from two places. One is from a values standpoint. I want to be helping the people who need the help the most. But secondly, when you think about it in terms of healthcare reform and just the impact on our country at large, so much inefficient care is delivered to folks who are socially vulnerable. In particular, I've had a focus on people who are dually eligible for Medicare and Medicaid. And it's just, the crime of, lack of efficiency that people are just sort of ping-ponging around the healthcare system. And as well as just not getting good care and therefore not getting good outcomes, it's just super unfortunate. And so I've always been, drawn to really targeting on this population that needs it the most, but that's also going to, probably cost the most. And so as a result, I've been, very focused on social drivers of health. Well before the private sector was focused on.
Or it was hip, or it was trendy to talk about.
Yeah, exactly. Right, shiny object.
It strikes me that if the goal is to really make the biggest impact on people's lives, or save the most money, or the combination of those things, the vulnerable populations that need the most dually eligible is a huge opportunity on both fronts. Is that fair?
100%. Yeah. And it goes beyond dually eligible. I mean, we are now working with payers across all lines of business. You have hourly workers and employer-sponsored plans who are definitely food and nutrition insecure, who have uncontrolled diabetes. So, the dually eligible, that's particularly bad because you have Medicare and Medicaid and the perverse incentives of, two different payers. But it definitely our target market and the market that the group of people I've always focused on goes across all lines of business, which can be surprising to some people.
Yeah, and so the social drivers of health. How did you start to focus on nutrition and food as the one social driver that you wanted to really spend, the large part of your time on? Because there's lots of pieces that you could focus on.
Yeah, well, a couple, a professional experience as well as a personal experience. Professionally at Oxford, when I was running Medicare, we started an outreach department that was really screening members for really social needs. And it just became so apparent. And today this is so blindingly obvious, but at the time, we recognized the connection between food insecurity and uncontrolled diabetes. And there were just pockets of uncontrolled diabetes, particularly in New Jersey, where we had expanded. And so it was very frustrating to sort of uncover this problem, but then at the time, really not be able to do anything about it. There really was not the flexibility at that point for a health plan to be paying for food. And so we certainly connected people to community-based resources, but many of the food banks at the time were primarily shelf stable, high carb food.
Right.
And so, I left that experience feeling, like I just had not done enough, and was just disappointed. And then subsequently, my son had some extreme sort of diet sensitivity that was just challenging developmentally, and we were really able to save the day through diet. And so the juxtaposition of the two, not being able to help a bunch of vulnerable seniors, but being able to help my one relatively fortunate N of one son, really just didn't sit well with me. And then secondly, I just thought about it in practical terms, like what is going to be the most impactful and what's going to be the most actionable. And so, as you said when we were talking before we started recording, food is so foundational to health. And so the potential impact is just so great. And then the other thing is food is such a connector. So it really gives us the opportunity to connect with people. First of all, to get the door opened, and then to be connected, and then to leverage that connection for actually much more than nutrition and food access. So those are all the reasons.
Well, I want to come back to that cultural and connection piece in a minute, but talk to me about the first pilot or first experiment or first time you tested this, when you thought, gosh, this could be a big opportunity to make an impact and have a real valuable company.
Yeah, for sure. So I had the good fortune of having my alma mater, the Mailman School of Public Health, initially support our launch. And through Mailman, I was connected to New York Presbyterian, and we were basically able to do a small sort of incubation with New York Presbyterian. And so it was a group of patients, all of whom had congestive heart failure diagnoses. Right. And basically we did sort of.
And around what year? I mean, I'm familiar with the Geisinger Fresh Food Pharmacy. Is it around that time or before that, a little after that? What was the... Which relevant year?
It was a little bit after that. It was 2019.
Okay. Yeah.
Yeah. But in any event, what we were able to find is that if we did a intake assessment and came to understand an individual's life with respect to food, so their taste avoidances, cultural cuisine preferences,
they're religious. They're the holidays they celebrate.
Exactly.
All of those things are so intertwined with food.
Right. And then functional dexterity and readiness for change, knowledge of nutrition, all of those things matter. So we basically figured out if we know enough about a person, we can figure out, what is the best food to get to this individual at this point in time. That will really serve almost as experiential education, like give people exposure to healthy food. And the initial program was very small. It was, just 40 patients, but we were able to show significant improvement in just patient-reported outcomes and very high levels of satisfaction. And so, that gave us the beginnings of the formula for what is now NourishedRx.
Yeah, I find that the small experiments I like to talk about, because that's where you can talk to all of the patients and really understand their experience, what they like, what they don't like, what is their personal experience that's maybe different than the labs that are coming back and reporting the outcomes. Did you find that experience that you could really engage with them?
Absolutely. We got a lot of great feedback. still serves us well today, actually.
Yeah.
I mean, but today as well, we do try to get as much feedback from our members as possible. In fact, we're launching a member advisory committee where a number of our members are reacting to different user interfaces, different protocols, and just giving us general
I like
insight from
this.
the
This could
point
be
of view.
better. I wish this was this way. Yeah.
Yep, exactly.
Let's back up for a minute. What is the mission and vision of NourishRx? What are you looking to do? What's the mission?
Yeah, so our vision is a world where poor diet is no longer the top driver of death, disease, and disparities.
Okay.
And our mission really is to drive health and health equity, one meal, one person, and one community at a time.
Okay, excellent. And what's the way you go to market, or how is this packaged? What's the business model? How do you approach it?
Sure. We're fully B2B2C, so we partner with health plans, also with risk-bearing providers, really anyone who is taking risk on outcomes and costs. And we basically work with them to target a particular subset of their membership that they believe would benefit from our services. So that ranges from people who have CKD, people who have CHF diagnosis, people with uncontrolled diabetes, and then we've also done some pregnancy programs, and or just more broadly.
So you have different programs, and the payer or the provider taking on risk can work with you to pick the one they want to work on, or maybe a series of them.
Exactly.
Okay.
And we, some of them are relatively broad. So for Medicare Advantage members who are eligible for special supplemental benefits for the chronically ill as designed by a particular health plan, and some are, very targeted, like BIPOC pregnancy, or someone who's screened as being at risk of food insecurity and also has a heart failure diagnosis.
Okay. And then food and nutrition, there's a lot of logistics and operations and patient education that's, I think, required. How do you address that to get your services out to the most people?
Yeah. So when I went to start NourishedRx, I really sort of assessed the food as medicine landscape. And my observation was that there were some great solutions out there, but they were really point solutions. So, medically tailored meals are good for a particular point in time for a particular group of people. You have produce prescriptions, you have, nutrition apps, for example. But what I recognized, and I think is bearing out to be true, is that for our target population, folks who are socially vulnerable, therefore likely to be food and nutrition insecure, it's really important to be able to provide a comprehensive solution. And so what we built really was a technology stack, a platform that can integrate amongst a number of partners. So we integrate with some fintech, we integrate with some telenutrition. We're in discussions to have a partnership with a obesity medical telehealth company. We partner with an array of prepared meal vendors. We partner with an array of grocery and produce vendors. And so we are facilitating and integrating, but we are not actually bearing the responsibility of the food production or the actual delivery. But our system is facilitating and providing what is the very best food for an individual at that point in time on their sort of dietary journey.
Yeah. So vulnerable populations are inherently, it's hard for them to access all the diversity of food that I have the luxury of accessing. And so you plug into existing grocery stores, existing meal plans, existing technology providers, and sort of leverage that and then bring it to the subscriber. Is that close?
Right. And right. And so basically we just have a broader tool belt.
Mhm.
And just like a physical therapist, when they see a patient in front of them, customizes the course of therapy for that individual, where we are able to do the same.
Okay. And how many states are you in, or what's the breadth of it right now, just in rough terms?
Yeah, for sure. Because our partners are both national in scale and also local in scale, we can cover all 50 states at this point.
Okay.
I'm not sure we've had members in every single of the 50 states, but I think we're probably up around 40.
Okay.
And we've worked with 10 different health plans at this point and served, over 10,000 members.
Yeah. Wow. Okay. And then help me understand and help the audience understand the benefits in maybe a case study or something that's more tangible. Like it's intuitive that bringing people education, access, guidance to eat more healthy, they would feel better and then have better outcomes. But do you have case studies or examples where that occurred?
Yeah, lots of them. I'll give you one example. We had a Medicare Advantage member named Mike, who was part of our congestive heart failure program. He also had obesity, and when we first enrolled Mike, we sort of wondered why he even enrolled, because he was so resistant to sort of every step of the onboarding and skeptical initially.
Yeah, because he opted in to do it, but then he was
right.
Yeah.
Right. And so over the course, this was a 1-year program, and I think the food delivery component of this program was about 2.5, 3 months in duration. But he pretty quickly, we started with prepared meals and coaching and different nutrition education. And he pretty quickly sort of exclaimed, like, wow, you guys are giving me so many more vegetables than I would normally eat. And I'm realizing I'm I have a lot more energy than I used to have. And he was losing weight. I think by month 1, he had lost something like 10 pounds. And then just as he went along, as we progressed, and we progressed him then to groceries with meal prep guidance, he really just got incredibly enthusiastic and really embraced the program. And my favorite part of this story is that he had been told as a child that if you add a spoonful of sugar to everything, it makes it better. And he had a real nostalgic attachment to that. His grandmother and his mother both did that. But he came to recognize that he also had blood sugar level problems. He came to recognize that he just couldn't add that spoonful of sugar. And so he got really creative and started mashing up blueberries to put in his vinaigrette that he had been always adding sugar to. And, thought it was so tasty that he actually ended up going around and sharing the recipe and the strategy.
He's almost an advocate to his neighbors and friends.
Exactly. And he did initially, we administer a number of screens and validated assessment tools to collect patient-reported outcomes. And he had scored high as being at risk of loneliness. And he admitted that he was lonely. He lived alone. He was a single man. Anyhow, ultimately, over time, he continued to lose weight. He reduced his diabetes medication. And when we circled back to him recently, because we wanted to see if he would be a member of our advisory committee, he reported that he had bought an RV and he was traveling cross country, visiting friends. Wow. And so no longer, socially isolated. He made sure he was taking a walk every day. And it was funny. I was actually hoping, I presented at Health. I was hoping that he had been a blackjack dealer in Las Vegas at one point long ago. And he had said that he was going to go back to Las Vegas and visit Las Vegas. And so I was hoping that there would be an opportunity to actually get him on stage with me. But yeah, it was just a tremendous turnaround, and we have story after story after story like that.
Yeah. So that makes me want to ask about the kind of like the transition where the first couple of months you're providing meal delivery and helping them understand the benefits of eating healthy, but then maybe do you transition the subscribers to be able to shop for themselves and then be much more self-sufficient? How is that trajectory so that you create lifelong, people that can maybe with some support feed themselves, nourish themselves?
Yeah, well, so first of all, I think it's important to call out that I think the real magic happens when someone has a paradigm shift. Like behavior change is very hard unless you start to sort of see the world differently. And so it's just really important that we drive that paradigm shift. And with our target population, you would be really surprised by just not only the lack of access, but the lack of broad exposure to healthy food. We hear all the time things like, "Wow, I never would have bought a cauliflower. I didn't
Yeah, I
really know
never would have eaten carrots, or I
Yeah,
don't like blueberries,
yeah,
even though they've never
exactly.
actually tried them. Yeah.
Exactly. And, it would have been a waste of money. I wasn't going to try something new. And so we try to make it super easy for someone to experience healthy food at first. We also practice harm reduction theory, where people tend to think of harm reduction theory and the concept in the vein of addiction treatment. Basically, you can't go cold turkey. You have to make sort of micro step changes. And so that's what we support. We are basically making it super easy for people to eat well. They then have that aha moment, like Mike did. Wow, I'm eating more vegetables, and I realize I have so much more energy.
Yeah. So
We
you're
then
not saying you can't, don't. You're just saying like try these vegetables, try the cauliflower, try broccoli, and then if you are full from kind of a well-balanced meal, you may not eat as much of the chips and other things that aren't great for you.
Right, exactly. Well, and when people start to recognize they're feeling better, and we're able to give them feedback because we've been tracking them, with different, we've been tracking different patient-reported outcomes, so we can give them that feedback. People are then motivated to really want to prepare their own food, and after that, after they do recognize that, gosh, it's actually pretty easy to do a healthy, tasty meal all on one sheet in the oven, then, they can go from receiving groceries and meal prep guidance from us to actually, acquiring the food themselves to the degree that they can. And
they're more motivated to find out where they need to go to get the food, because it may be possible, but it's not right in the corner. Is that fair? Like depending on the neighborhood, maybe.
It depends on the neighborhood, but we will support people getting enrolled in SNAP or in WIC, for example. We'll support people on SNAP to basically use their EBT dollars so that they can get home delivered food. And so many more people now, thanks to the Instacarts of the world and Walmart, who do accept those SNAP EBT, that payment mechanism, are able to get that food. And so we support not only how do you prepare the food, but how do you best navigate your own food landscape. And that even goes as far as, okay, you only have a Dollar General to shop in. Here's what we recommend you getting in the Dollar General.
Mm-hmm. Yeah. So you can advise them on the best options there.
Right.
It may not be ideal. It's the best they can do at that moment.
Right. Exactly.
Interesting. Talk to me about, let's shift back to the cultural aspects of food, because a lot of the foods that we all grew up eating at holidays or that our grandparents made they dropped in a spoonful of sugar, partially because they didn't know, partially because it just was a cultural thing before the whole society knew that it was so important to health. How do you make that transition where it's culturally acceptable and sort of recognizes the kind of central part that food has in culture while teaching them about maybe healthier options?
Yeah, so it's really a two-part process. First of all, whenever we have a concentration of members in a particular MSA, we are able to partner with local food partners. And so we can basically vet and credential those partners and work with them to adapt recipes so that they, sort of suit the nutrition guidelines that we need. And so, that ranges from a Somali kitchen in the Twin Cities in Minnesota to, a Cuban kitchen in southern Florida. And so that
is it fair to say that all of these cultures can be adapted to be healthy, or can largely be adapted?
Yeah, absolutely.
Or at least more healthy than they are.
Yes, absolutely. And I think our registered dietitians would agree with me here that sodium is the biggest sort of threat to healthy eating that's in most of the food that any of us eat outside of our homes. So that's one of the first targets for us when we're adapting recipes.
Yeah, I've taken a couple cooking classes with chefs here in Nashville just for fun. And that was the thing that really shocked me, is the amount of salt and butter that they are putting in, because it helps the taste in the restaurant, and that's okay for once in a while, but maybe it's better to correct that over time.
Totally. Yeah, totally.
Yeah. Okay. Talk to me about your hopes for where NourishRx can go, and also the food as medicine movement, or the impact that this could have on, honestly, our country needs a lot of help in getting better health outcomes. I see food as a pretty inexpensive version of medicine, and I want to get your thoughts on where this is headed.
Yeah, for sure. But just to frame it and put it in context and agree with you, over 700,000 people die annually from diet-related disease. And to put that in context, that's more people dying than died from COVID at the very height of the pandemic. Yeah. And so it just shows you, how inured we are as a culture to diet-related disease. And we run into this all the time where, people are like, wow, I just thought, diabetes was sort of a regular part of aging. So there's so much opportunity if we can really address nutrition, in a way that it deserves to be. So on a national scale, super exciting. The Biden administration hosted the first conference on hunger, nutrition, and health in 50 years in September of 22. Just this past January 31st, HHS hosted a Food as Medicine Summit. So there's a lot of focus and attention and recognition, that there's just great potential here, especially in the context of value-based care, to really integrate nutrition and food access into healthcare delivery and, really get a flywheel going, that where the return on investment for the healthcare payer is significant enough that, there's a real interest in just continuing these programs on a recurring basis. Yeah. And so we're feeling that happen, all over the place. I mean, at NourishedRx, we've gone from doing pilots and generating proof points to now operating, I think we're up to 6, soon to be 9 recurring revenue programs.
Yeah. Well, the great thing about delivering a hard dollar return on investment and happier members is those pilots then turn into longer term thing, because all payers and value-based care organizations want both those things.
Absolutely.
Yeah.
Absolutely. So yeah, so that's, where I see it going. I think that the flywheel is getting moving, and you have more and more payers really focused on food as medicine, and recognizing that it's not only an opportunity to drive down medical costs, but it's an exceptional engagement opportunity. It's even an opportunity to drive health plan retention, to drive really positive health plan member experience that actually ends up showing up in their star ratings.
Right.
And then now CMS is starting to hold the plan's feet to the fire with respect to health equity and the health equity index.
Right.
And I can't think of a more actionable way to address health disparities than by addressing nutrition security.
Yeah, I agree with that. It's exciting to me because I think it might be the only effective counterbalance to the very large economic kind of machines of the food industry and the convenience, fast food, and kind of instant gratification, which drives a lot of TV ads and social media ads, and there hasn't been enough money on the healthy, farm to table movement. But we spend so much money in healthcare on chronic disease that if we can tie those together, now we have a counterbalance to really sort of at least make it more even, more of a fair fight to bring healthy food out there.
Right. Yeah, I like to say that the perverse incentives of the healthcare system are, interacting with the perverse incentives of the food system, and
they're fighting with each other.
Basically exacerbating one another.
Mm-hmm.
Yeah, no, I totally agree with you. And it's not only, we're getting the flywheel going in terms of payers recognizing that there's a real return for them, but also just getting the word out, more and more members, socially vulnerable folks who have just not had exposure to healthy food, very little exposure to nutrition as a science. We're just getting the word out will I think continue the movement and improve it over time.
Yeah. So I've experimented with a decent amount with diet. How many days does it take for you to get a member until they start feeling better? Is it somewhere between 30 and 60 days in my experiments is what it takes to sort of to feel different? Is that close to what your science is?
I think that's right. Yep. 30
so
to
if you can get them to focus and try to, sort of suspend disbelief and trust NourishRx, maybe because a friend recommended them or because it's a benefit they're getting for 2 months, then they could have the experience Mike has, where his whole outlook on life, maybe that's too ambitious, but I'm going to say that his whole
I think it truly does. It did change his whole outlook on life.
Yeah. Okay, and then there's one controversial topic I want to get your take on. Everyone's been following the GLP-1, craziness. It's like the perfect American values shot, right? Like you just take the shot and you lose weight without doing anything else. I worry about that. Not that I have any facts, but I just worry that if it's too good to be true, maybe it's too good to be true.
Yeah.
What are your thoughts? Like, is it a good way to catalyze this change of behavior and then we can get people eating healthy and taper? Or is it going to be really, really a bad ending or somewhere in the middle?
Yeah. Well, so again, remember my target audience.
Yeah, your target audience is not focused
on.
Well,
no, they are. I mean, 40% of employers are actually covering GLP-1s for employees, and so that includes hourly workers who. I
cannot believe 40% are covering it, but that's great.
Yeah. I mean, there can be all kinds of requirements associated with it, but yes, and I can't tell you where I got that statistic, but
well, it's a significant number, whether it's 40 or 38 or 42.
Yeah. But so we've had, as the way I see this GLP-1 craze, is it's almost like the straw that broke the camel's back for the payers. I mean, the cost of diet-related disease, the cost of diabetes, obesity, kidney disease, has been reaching a boiling point for quite some time. And yet, as we talked about before, it's almost like we're all inured to it. But now this like extra, sort of eye-popping cost of GLP-1s is really getting the payers to focus. So for us, it's really been interesting. It's been like a whoosh of tailwinds for us because payers are really hoping that, programs like ours can be a companion therapy that might forestall the use of expensive pharmacotherapy or might foreshorten the use of expensive pharmacotherapy, or at least will improve the outcomes and then reduce, the total cost of care over time. And
they might require that a prescriber try this first, or try it in as a companion, or any combination of those things, right?
Right. And in obesity medicine, ideally you don't require they do it beforehand, but you offer it to them. I mean, that would be like, requiring someone who has hypertension to do something and not giving them, meds for hypertension. But that it's definitely being talked about for sure. And I'm super optimistic about, working with our target market in that because people have never had exposure to healthy food frequently, we know a core cause of the obesity they're experiencing is likely to be poor diet, like lots of ultra processed food. And so if we can work with someone and really shift their diet dramatically, either before or during the pharmacotherapy, I think the potential to really taper, the food, their diet pre-pharmacotherapy could look very different, a year in.
Right.
And so the potential to taper, I think, is huge in particular.
Yeah. To me, that's the optimistic view, is that it is a catalyst to get people to lose weight and feel the effects quickly. And then they start eating healthy. And I don't think it's a good thing to be, taking a shot once a day or once a week for your life. Tapering over time, I think, could be really good if we can balance it all and get it all to sort of fit together.
Right. No, I agree with you, but I do defer to the obesity medical experts who are out there. But
yes, that's right. I play a podcast host during the day, but I have no expertise with this stuff. Okay, what have we not covered that we should have covered around nutrition and sort of affecting people's health through food?
I think, I've alluded to this before, but I think many of us in healthcare don't really recognize what a driver of, poor outcomes and costly healthcare, nutrition, and lack of food access is. And so I think, it's just time for us to all open our eyes and really recognize that. And then I think the second piece is that's just alarming is there's such a prevalence of people who've never had exposure to healthy food. And again, just the science of nutrition is completely impractical and irrelevant to their lives because they don't have access to, or they've just never had exposure to healthy food. And so I think just recognizing that
it's
reality.
kind of handed down from parent to child. But if your parents were not focused on nutrition except to get calories to get through the day, then that's what you grew up with, and you don't really learn anything different. And it takes someone like you or someone at NourishRx to sort of break that trend and teach someone.
Give exposure, yeah. Have someone have that paradigm shift.
Yeah. I like how you've shifted it, and it's a trend now. It used to be social determinants of health. Now it's sort of the social drivers of health. because it's much more empowering that like
Right.
I can take control of my own nutrition as opposed to it being like determined from some outside area.
Yep.
And I think that's a easier way for providers too to think about it. Like, okay, if I'm going to treat these patients, what are the drivers that are contributing to their health or their poor health? And maybe their meds and exercise is one of them, but nutrition is certainly a big one too.
Right. Absolutely.
Yeah. Okay. Well, Lauren, thanks for doing this. I learned a lot. I think the audience will have learned a lot. Where is the best place for people to learn more about NourishRx?
Sure. Please go to our website, www.nourishrx.com.
Okay. I'll put that in
We
the show
also have a
notes.
pretty active LinkedIn account and Instagram as well.
Okay. Excellent. Well, thanks for doing this. I really appreciate it. We will link to your website and LinkedIn and Instagram in the show notes, so people can just click right below and get over and learn more and follow it. They probably have programs with NourishRx with one of their payers in their local community, because you're in a lot
They
of.
very well may. Yep.
Okay. Thanks, Lauren.
Okay.
I appreciate it.